Hello everyone, and welcome back to the channel. Today we are diving into one of the most incredible transformations the human body can undergo, pregnancy. Think about it for a moment. Over the course of roughly 40 weeks, the body orchestrates a symphony of anatomical and physiological changes to grow a brand new human being from just 2 cells. It is a process that is both beautifully complex and elegantly simple. For anyone stepping into the world of medicine, whether you are a medical student, a future nurse, or an allied health professional, understanding this journey is not just an academic exercise, it is absolutely fundamental to providing excellent, compassionate care to your future patients. So, let's get into it. This is not just a story about a baby growing, it is a story about the maternal body adapting in ways that are nothing short of miraculous. We are going to break down these changes system by system, trimester by trimester. We will explore how the body makes space, ramps up its resources, and prepares for the final act of childbirth. This knowledge is your foundation. It will help you understand why we monitor certain vitals, why patients experience specific symptoms like morning sickness or back pain, and how to spot when something might be going awry. It is the why behind the what of obstetric care, and mastering it will make you a more confident and competent practitioner. Our goal today is to make this complex topic as clear and accessible as possible. We will strip away the intimidating jargon and focus on the core concepts you need to know. We will talk about the uterus expanding to the size of a watermelon, the heart working nearly 50% harder, and even why pregnant women might feel short of breath just climbing a flight of stairs. Each change has a purpose, a clinical significance that you will encounter daily in your careers. By the end of this, you will have a solid framework for understanding the anatomy of pregnancy. You will be able to connect the dots between a symptom and its underlying anatomical cause, which is a crucial skill for any healthcare provider. So, grab your notebooks, get comfortable, and prepare to be amazed by the sheer ingenuity of the human body. We are going to take this step by step, ensuring you grasp every detail along the way. Think of this as your guided tour through the anatomy of creation. This is not just about memorizing facts. It is about building a deep appreciation for the process and equipping you with the knowledge to support patients through this life-changing experience. Remember, every great medical professional starts with a strong understanding of the basics. Let's build that foundation together, right here, right now. Let's begin this incredible journey. All right, let's start at the very beginning, at the moment of conception. This is where it all kicks off. Conception typically occurs in the fallopian tube, one of the 2 slender tubes connecting the ovaries to the uterus. When a sperm successfully fertilizes an egg, a new, single cell, called a zygote, is formed. This tiny structure, containing the complete genetic blueprint for a new individual, does not just sit there. It immediately begins a remarkable journey. It starts dividing rapidly, becoming a blastocyst, a small cluster of cells, while traveling down the fallopian tube towards the uterus. This journey takes about 6 to 12 days, a critical period where the very first steps of development are taking place. Once our little blastocyst reaches the uterus, its next major task is implantation. This is a crucial event. The blastocyst must burrow into the uterine wall, known as the endometrium, which has been specially prepared for its arrival. Think of the endometrium as a rich, nutrient-dense soil ready to nourish a seed. Hormones, particularly progesterone, have made this lining thick and vascular, creating a welcoming environment. The blastocyst attaches itself and begins to invade the tissue, establishing a connection with the maternal blood supply. This connection is the lifeline that will sustain the embryo for the next 9 months. It is at this point that pregnancy is truly established. From a clinical standpoint, this early stage is incredibly delicate. A significant number of pregnancies fail at the implantation stage, often before the person even knows they are pregnant. Successful implantation triggers the production of a key hormone, human chorionic gonadotropin, or HCG. This is the hormone detected in home pregnancy tests and blood tests. HCG's primary job is to tell the body, hey, we are pregnant. It signals the ovaries to keep producing progesterone, which maintains the uterine lining and prevents menstruation. Without this hormonal signal, the uterine lining would shed, and the pregnancy would be lost. This is why HCG levels are often monitored in early pregnancy to confirm viability. So, to recap this initial phase, we have fertilization in the fallopian tube, a journey to the uterus, and the critical process of implantation, into a hormonally prepared endometrium. This sets the stage for everything that follows. The establishment of this physical and hormonal link between the embryo and the mother is the foundational event of pregnancy. It is the biological handshake that says, okay, we're in this together. Understanding this intricate dance of anatomy and endocrinology is your first step to appreciating the complexity and fragility of early pregnancy. It is the quiet, unseen beginning of a monumental 9-month project. Now that implantation is complete, we enter the first trimester, which spans from week 1 to the end of week 12. This period is all about rapid development and laying down the fundamental structures of the new human. The implanted blastocyst develops into an embryo, and this is when organogenesis, the formation of organs, occurs. The heart begins to beat, the neural tube, which will become the brain and spinal cord, closes, and tiny buds that will eventually become arms and legs appear. By the end of this trimester, the embryo is now called a fetus, and all major organs are in place, although they are still very immature. It is an incredibly busy and vulnerable time. For the mother, the first trimester is often a whirlwind of hormonal changes, even if there are not many obvious external signs of pregnancy yet. The surge in hormones like HCG, progesterone, and estrogen is responsible for many of the classic early pregnancy symptoms. Morning sickness, or more accurately, nausea and vomiting of pregnancy, is largely attributed to rapidly rising HCG levels. Fatigue is another common complaint, as the body is pouring an immense amount of energy into building the placenta and supporting the growing embryo. The body is essentially working overtime on the most important construction project of its life, which can be absolutely exhausting. Clinically, the first trimester is a period of close monitoring and confirmation. This is when the first ultrasound is often performed to confirm the pregnancy is located within the uterus, ruling out an ectopic pregnancy, to check for a heartbeat, and to establish a more accurate due date. An ectopic pregnancy, where the embryo implants outside the uterus, most commonly in the fallopian tube, is a medical emergency because the tube can rupture as the embryo grows. This is why confirming the location is so critical. This trimester is also the time when the risk of miscarriage is highest, as major developmental processes are underway, making the fetus susceptible to genetic errors or external factors. Understanding the anatomy and physiology of this stage is vital for patient education and reassurance. When a patient complains of extreme tiredness or constant nausea, you can explain the powerful hormonal shifts driving these symptoms. You can reassure them that in most cases, these are signs of a healthy developing pregnancy. Your role is to guide them through this period of uncertainty, providing evidence-based information and support. Explaining that their body is building a literal life support system, the placenta, can help them understand the profound fatigue they feel. It is a time of immense biological work, hidden from view but intensely felt. Let's focus on two of the most obvious anatomical stars of the pregnancy show, the uterus and the breasts. The uterus undergoes one of the most dramatic transformations of any organ in the body. Before pregnancy, it is a small, pear-shaped muscular organ, weighing only about 70 grams and holding a volume of about 10 milliliters. By the end of pregnancy, it will have expanded to weigh around 1,100 grams and can hold a volume of 5 liters or more. That is a 500-fold increase in capacity. This growth is not just simple stretching, it involves both hypertrophy, an increase in the size of existing muscle cells, and hyperplasia, an increase in the number of muscle cells, driven by estrogen. As the uterus grows, it changes from a pelvic organ into an abdominal organ. By about 12 weeks, it is just rising above the pubic bone. By 20 weeks, it typically reaches the level of the umbilicus, or belly button. And, by around 36 weeks, it reaches its highest point, right up against the xiphoid process, the bottom tip of the sternum. This progressive enlargement is a key clinical marker we use to track fetal growth. Measuring the fundal height, the distance from the pubic bone to the top of the uterus, gives us a good, albeit rough estimate of whether the baby is growing as expected. This simple measurement is a staple of every antenatal checkup. Meanwhile, the breasts are also undergoing significant preparation. From early in the first trimester, they often become tender, swollen, and larger. This is due to the influence of estrogen and progesterone, which stimulate the growth and branching of the milk ducts and the development of the milk-producing glands, called alveoli. The areola, the pigmented area around the nipple, often darkens and enlarges, and small bumps on its surface, called Montgomery's tubercles, become more prominent. These are sebaceous glands that secrete an oily substance to lubricate and protect the nipple in preparation for breastfeeding. By the second trimester, the breasts are capable of producing milk. From about 16 weeks onwards, they may even leak small amounts of a yellowish, thick fluid called colostrum. This is often called liquid gold because it is the first milk the baby will receive, and it is incredibly rich in antibodies and nutrients. These changes are all about getting the factory ready for production. The body is not waiting until the baby arrives. It is preparing the feeding equipment months in advance. For patients, these changes can be uncomfortable, so recommending supportive, well-fitting bras is a simple but important piece of practical advice you can offer. It is another example of anatomy directly impacting patient comfort and care. Now let's talk about the engine room of the body, the cardiovascular system. During pregnancy, this system goes into overdrive to meet the increased metabolic demands of both the mother and the growing fetus. One of the most significant changes is a massive increase in blood volume. By the third trimester, a pregnant person's total blood volume increases by a staggering 40 to 50%. That is almost an extra 1.5 liters of blood circulating in the body. This expansion is necessary to perfuse the placenta, supply the fetus with oxygen and nutrients, and also to provide a safety buffer for the blood loss that will inevitably occur during childbirth. To manage this extra volume, the heart has to work harder. Cardiac output, which is the amount of blood the heart pumps per minute, increases by 30 to 50%. This is achieved through both an increase in heart rate, which typically rises by about 10 to 20 beats per minute, and an increase in stroke volume, the amount of blood pumped with each beat. You might notice that a pregnant patient's heart sounds slightly different, perhaps with a more pronounced beat or even a benign flow murmur, which is just the sound of more blood moving swiftly through the heart's chambers. The heart muscle itself may even undergo some slight temporary enlargement to handle this increased workload. An interesting consequence of this is something called physiological anemia of pregnancy. While the body produces more red blood cells to carry oxygen, the plasma volume, the liquid part of the blood, increases even more. This dilutes the concentration of red blood cells, leading to a lower hemoglobin level on a blood test. This is a normal expected finding and is different from true iron deficiency anemia, although that can also occur. This is why we monitor hemoglobin levels throughout pregnancy and often recommend iron supplements to ensure the mother has enough iron to make all those extra red blood cells for herself and the baby. Another key clinical point is blood pressure. Despite the huge increase in blood volume and cardiac output, blood pressure typically does not rise. In fact, it often drops slightly during the first and second trimesters. This is due to the hormone progesterone, which relaxes smooth muscle and causes vasodilation, or a widening of the blood vessels, reducing peripheral resistance. This is a protective mechanism. However, a rise in blood pressure in the second half of pregnancy can be a red flag for a serious condition called preeclampsia, which is why blood pressure is meticulously checked at every single antenatal visit. Understanding these baseline changes is crucial to spotting that dangerous deviation. As the uterus grows upwards, it inevitably starts to crowd the other organs in the abdominal and thoracic cavities. Let's look at the respiratory system first. As the diaphragm gets pushed up by the enlarging uterus by as much as 4 centimeters, you might think that lung capacity would decrease. But the body cleverly compensates. The rib cage actually flares out and widens, increasing its total circumference. This change, driven by hormones like relaxin, allows the lungs to maintain their total capacity. However, the way a person breathes does change. They rely less on diaphragmatic breathing and more on thoracic or chest breathing. This upward pressure on the diaphragm can lead to a common symptom, dyssynoia, or sensation of breathlessness. Many pregnant individuals report feeling short of breath even with minimal exertion. This is not just due to the mechanical pressure. Progesterone also acts as a respiratory stimulant, increasing sensitivity to carbon dioxide. This makes the person breathe more deeply and frequently, a state known as hyperventilation of pregnancy. The goal is to blow off more carbon dioxide to create a favorable diffusion gradient, helping to efficiently transfer the fetus's waste carbon dioxide across the placenta into the maternal bloodstream. So that feeling of breathlessness is often the body's way of ensuring the baby gets enough oxygen. Now, let's turn to the digestive system, which also gets significantly rearranged. The growing uterus displaces the stomach and intestines upwards and backwards. This, combined with the relaxing effect of progesterone on smooth muscle, slows down gastrointestinal motility. Food moves more slowly through the stomach and intestines. While this has the benefit of allowing more time for nutrient absorption, which is great for the baby, it comes with some uncomfortable side effects for the mother. This slowing is a primary cause of constipation, a very common complaint during pregnancy. It is a simple mechanical and hormonal issue. This same combination of mechanical pressure and hormonal relaxation is responsible for another classic symptom, heartburn, or gastroesophageal reflux. The lower esophageal sphincter, the muscular valve that keeps stomach acid from splashing up into the esophagus, becomes more relaxed due to progesterone. At the same time, the growing uterus increases intra-abdominal pressure, physically pushing stomach contents upwards. It is a perfect storm for acid reflux. This is why advising patients to eat smaller, more frequent meals and to avoid lying down immediately after eating can provide significant relief. It is a practical solution based on a clear understanding of the anatomical changes at play. The musculoskeletal system undergoes a huge amount of strain and adaptation to support the growing weight of the pregnancy. As the uterus expands forward, the mother's center of gravity shifts. To compensate and avoid falling over, she develops a characteristic posture. She leans back, increasing the curvature of her lower back. This posture is called lumbar lordosis. While it helps maintain balance, it puts a significant strain on the lower back muscles and joints, which is a major reason why lower back pain is so incredibly common, affecting a majority of pregnant individuals. It is a direct anatomical consequence of carrying the extra weight out in front. The body also prepares for childbirth by loosening up the pelvic joints. The hormone relaxin, along with progesterone, softens ligaments throughout the body, but it has a particularly pronounced effect on the pelvis. The ligaments connecting the pubic symphysis, the joint at the front of the pelvis, and the sacroiliac joints at the back become more flexible. This allows the pelvis to have a bit more give and expand slightly during delivery, helping the baby to pass through the birth canal. The downside is that this ligamentous laxity can lead to instability and pain, a condition known as pelvic girdle pain. It can also cause a waddling gait, which is very characteristic of late pregnancy. The urinary system is another area that feels the pressure, quite literally. In the first trimester, the enlarging uterus puts pressure on the bladder, leading to increased urinary frequency. This symptom often gets a little better in the mid-trimester as the uterus rises up into the abdomen, lifting off the bladder. However, it returns with a vengeance in the third trimester when the baby's head descends back down into the pelvis, once again compressing the bladder. This reduces the bladder's capacity, meaning it fills up more quickly and sends the eye need to go signal more often, even with small amounts of urine. Furthermore, the kidneys themselves are working harder. The renal blood flow increases significantly to help filter the increased blood volume and get rid of waste products from both the mother and the fetus. The ureters, the tubes that carry urine from the kidneys to the bladder, also dilate due to the relaxing effect of progesterone. This dilation, along with some compression from the uterus, can slow the flow of urine. This state of urinary stasis increases the risk of urinary tract infections, or UTIs. This is why we screen for and promptly treat UTIs in pregnancy, as they can potentially lead to more serious kidney infections if left unchecked. The profound hormonal shifts of pregnancy manifest in many ways, including noticeable changes to the skin. One of the most common is hyperpigmentation, or the darkening of the skin in certain areas. This is caused by increased levels of melanocyte-stimulating hormone. You will see this as the linea nigra, a dark line that runs down the middle of the abdomen from the belly button to the pubic area. The areolae of the nipples and sometimes the skin of the face also darken. On the face, this is called melasma, or the mask of pregnancy. These changes are generally harmless and usually fade after delivery, but they can be a source of cosmetic concern for some patients. Another very common skin change is the appearance of stria gravidarum, better known as stretch marks. These are caused by a combination of factors. The rapid stretching of the skin over the growing abdomen, breasts and hips is the primary mechanical cause. However, increased levels of steroid hormones can also affect the skin's connective tissue, making it more susceptible to tearing. These small tears in the dermis result in the reddish or purplish lines that eventually fade to a silvery white color after pregnancy. While many creams and oils are marketed to prevent them, their effectiveness is limited as the cause is largely mechanical and hormonal. Of course, the endocrine system is the master conductor of this entire orchestral performance. We have already touched on key players like HCG, estrogen, and progesterone, but their roles are vast. Estrogen is crucial for the growth of the uterus, the development of the milk ducts, and increasing blood flow. Progesterone is the great maintainer of pregnancy. It keeps the uterine muscle relaxed to prevent premature contractions, maintains the uterine lining, and plays a role in almost every system change we have discussed, from vasodilation to slowed digestion. The placenta itself becomes a major endocrine organ, taking over progesterone and estrogen production from the ovaries by around the 10th week. Towards the end of pregnancy, other hormones like relaxin and prostaglandins become more important. As we mentioned, relaxin softens ligaments in the pelvis, but it also helps to ripen or soften and thin out the cervix in preparation for labor. Prostaglandins also play a crucial role in cervical ripening and initiating uterine contractions. The intricate interplay and timing of these hormonal shifts are what guide the body through 9 months of growth and then seamlessly transition it into the process of labor and delivery. It is a beautifully complex and finely tuned system where every hormone has a specific job to do at a specific time. So, there you have it, an anatomical and physiological tour of the incredible journey from conception to birth. We have seen how nearly every system in the body adapts, remodels, and works over time to support the growth of a new life, from the heart pumping 50% more blood, to the rib cage flaring out to make room for breathing, to the ligaments of the pelvis loosening for birth. Each change is purposeful and interconnected. It is a testament to the remarkable adaptability of the human body. Understanding this is not just about passing your exams, it is about building the empathy and clinical acumen needed to care for your patients effectively. When you understand the why behind the symptoms, you can provide better education, reassurance, and care. You can explain to an exhausted first trimester patient that her fatigue is the result of her body building a life support system. You can explain to a patient with back pain that it is a direct result of her changing center of gravity. This knowledge transforms you from a technician into a true caregiver. It allows you to anticipate problems, like the increased risk of urinary tract infections, or the significance of a sudden rise in blood pressure. It empowers you to be a proactive and knowledgeable member of the healthcare team. This foundation is your starting point. As you progress in your careers, you will build upon this knowledge, seeing these principles play out in real patients every single day. You will learn to recognize the subtle variations from the norm and develop an intuition for when things are going right and when they are not. Never lose your sense of awe for this process. Pregnancy is a normal physiological event, but it is anything but ordinary. It is a profound transformation that deserves our respect, our attention, and our deepest understanding. Keep asking questions, keep being curious, and keep learning. Thank you so much for joining me today. I hope this breakdown has given you a clear and solid understanding of the anatomy of pregnancy. If you found this helpful and want to keep learning with us, make sure you hit that subscribe button for Joan Academy. We are constantly putting out new content designed to help you succeed on your journey in medicine. Stay curious, work hard, and I will see you in the next video.